Hi, and welcome back to the Blood Bank Guy video podcast. My name is Joe Chaffin. For the next hour or so, I'm going to be your tour guide through an overall kind of big picture look at the blood groups. There's a lot of information to cover in this lecture and not a lot of time to do it, so I'm going to go fairly quickly, just warning you right up front. As always, I need to let you know that this is being recorded in December 2011. As a result, I've made this as up-to-date as possible at that date, but depending on when you're listening to this, the new information may or may not have come out. As I said, it's December 2011 and we are in Colorado, so this is, as I look out my window to the right, well, you're not in Colorado, maybe. I'm in Colorado. As I look out my window to the right, this is what I'm seeing. It's a little depressing, but what's even more depressing is when I turn back to my left and look at what I'm going to be staring at for the next hour or so, and that's this. So I'll do my best to lecture against a wall with some degree of entertainment for you, I hope. Anyway, over the next hour or so, this is what we're going to do. The first thing you should know is that there is a handout available. Please go and get it. Pause the presentation right now if you don't already have the handout, because you will need it. I think it'll be useful to you. Go to www.bbguide.org. Click the podcast tab and go to this lecture, which is Blood Groups Overview. Basically, those of you that have heard me lecture at the Osler Institute Pathology course and have heard some of those lectures on CD or MP3, you'll know that this is kind of a variant of what I called Blood Bank 1 at the Osler course. And in fact, if you look at the bottom left of the slide here, the reference on many of the slides as we go through today will tell you exactly where we are in that Blood Bank 1 handout. This is the first of a series of at least 3, probably 4 immunohematology lectures. Excuse me. After this one, I'll record pre-transfusion testing, and then we'll do most likely a 2-part series on antibody identification. It's designed to kind of take you from the ground up. We're obviously, in that short a time, we can't cover everything, but we're going to cover as much as we can. Today, we're going to do the background and basics of the blood groups. It's in some degree of detail, but not as much detail as you will hear in the pre-transfusion testing podcast, which is, as I said, going to be recorded next. So we'll just kind of skim over that. Then we'll go specifically through the blood systems, specifically looking at what I call the enzyme classification. I'll explain that to you in just a little while. Basically categorizing the blood systems by the blood systems / blood groups by their reaction with proteolytic enzymes. And then we'll hit some miscellaneous groups at the end. As I said, that'll take about an hour or so, probably a little over. I apologize in advance if I talk quickly, but there is a lot to cover. So let's get started. As far as the background, we start with the basic reactions in blood banking. Certainly the most basic reaction in blood banking is agglutination. And you see here on the right side of the screen an example of red cells being agglutinated by IgG antibodies on the top and IgM antibodies on the bottom. Certainly IgM is much better at doing that than IgG. IgM antibodies tend to react in lower temperatures. IgG antibodies tend to react in warmer temperatures, and that's some of the difference between warm antibodies and cold antibodies that we'll talk about in just a little while. There are 3 classic phases of testing, in particular testing that's done in a test tube that you should be well aware of and well familiar with. And those 3 phases you see here on the slide are the immediate spin phase, the 37-degree phase, and the IAT, or anti-human globulin phase, also known as the Coombs phase. Basically, what those are designed to do is it's a testing pattern designed to determine the presence of antibodies that may be what we call clinically significant, meaning that they have the capability to cause hemolytic transfusion reactions or hemolytic disease of the fetus and newborn. In general, the antibodies that are most significant are those that react either at 37 degrees and or at the IAT phase, specifically the IAT phase. That's certainly the most important phase. You see at the top of the screen on the right an example of a negative tube test on the left and a strongly positive tube test on the right. There are certainly alternatives to tube testing. In fact, the majority of laboratories in the United States now use alternatives to tube testing, including gel testing or solid phase testing. And again, you'll hear more about this in the pre-transfusion testing lecture, but this is just an example of gel testing with a very strong positive on the left side of the image and a complete negative on the right side of the image. If you're not familiar with gel, again, we'll discuss that further in the next lecture. Solid phase testing, on the other hand, is my personal favorite in terms of these types of testing. I have a long background in solid phase testing, and solid phase testing is different than gel in that you're doing the test in a very small little micro well, and it's a little confusing. Again, more on this in the pre-transfusion testing lecture. But if you look at the images here, if you look at these two close-up views of wells at the bottom left of the slide, you'll see that a positive actually is a diffuse carpet of those indicator red cells, and a negative is a pellet at the bottom of the tube. And that may be a little confusing to those of you that haven't seen solid phase before. Again, if that's not clear to you, we'll hit that more in the pre-transfusion testing lecture. It's important that you understand the indirect antiglobulin test. The IAT is designed to detect the presence of antibody-antigen interaction that occurs in vitro. In our example here on the slide, it's antibody-antigen interaction that occurs in a test tube. So for example, when antibodies are present and the corresponding antigen is present on the surface of red cells, that interaction occurs in the test tube. You get coating of the cells, but not necessarily agglutination. That happens commonly with IgG antibodies. Then you go on, you wash away any unbound antibodies, add anti-human globulins, shown as little blue Ys or antibodies here on this slide, and those agglutinate by binding to the antibodies themselves. Lots of different ways to do the IAT, and that's a very simple look at it. The DAT, on the other hand, simply looks for the presence of that same sort of interaction, in other words, antibodies binding to red cells, that occurs in vivo, in other words, in the body. So you pull the red cells off, you do a washing step to wash away any unbound antibodies, and again, you add the anti-human globulin and get agglutination, as you see there. Dosage is an important term for you to understand. We're going to mention it a couple times as we go through the different blood groups, so let me just hit it here quickly. Imagine that we have a fake blood group called the ZY blood group, and in that ZY blood group, you have obviously two different alleles. You have the Z allele and the Y allele. So if the individual on the top of this slide is homozygous for the Z the Z gene, and in other words, their genotype is ZZ, and you react their red cells with anti-Z, and you get a strong reaction. Okay, we're making this up, by the way. This is not based on reality, but this is how dosage works. On the other hand, the person on the bottom has the ZY genotype. In other words, they are heterozygous or have only a quote-unquote single dose for the Z antigen. If their red cells react weaker with anti-Z, as you can see, the 1+ reaction at the bottom of the slide, then that antibody, by definition, anti-Z, shows dosage. This is fairly common in regular blood group antigens in real life. The KID, Duffy, RH, and MNS systems have a tendency to have antibodies which show substantial amounts of dosage, and again, we'll talk about that a little bit as we go on through the different groups. Let's take a quick look at proteolytic enzymes. I mentioned that earlier, that we're going to define our blood groups based on their reaction with proteolytic enzymes. And this confuses people a little bit, so I'll hit it here a little and a little more in the pre-transfusion testing section. With enzymes, basically, you take enzymes that cleave proteins, such as physin and papain, for example. What they do is they may change the way that antibodies bind to red cells, and may increase or decrease the amount of agglutination that you get. And that occurs as a result of either direct manipulation of the antigens or as manipulation of the environment around the antigens. Let me just kind of show you how this works. So let's imagine that this is the surface of a red cell. And if you look at the surface of a red cell, there's a lot of protein sticking up off the surface. This is just an example of Glycoforeign A, for example. There's about 1 million Glycoforeign A antigens sticking up from the surface of a red cell. Okay, if that's the case, Glycoforeign A carries several antigens, including the M antigen. So here we have the M antigen sitting on a Glycoforeign A. Well, you throw in a proteolytic enzyme. This is a glycoprotein on the surface. You throw in a proteolytic enzyme, and our friend the little Pac-Man comes in and does its thing and actually cleaves some of these proteins. You lose some of them, and guess what happens to your M expression? You get a decreased amount of M antigen expression. That seems pretty obvious, right? So that's a direct manipulation, a direct decrease of the amount of antigen, and you would expect an anti-M to react weaker after that sort of a treatment. On the other hand, that same glycoprotein, or Glycoforeign A, since it's present in such a large quantity on the surface of the red cells, it has a tendency to mask some of the antigens that bind or that are present closer to the surface of the red cells. And one example of that are Rh antigens. This is just a schematic, obviously, of how Glycoforeign A waves far above the surface, and the Rh antigens are found closer to the surface. So an antibody against Rh can come along, try to bind, but be blocked by that Glycoforeign A. Now, obviously, this is just an example or a schematic because, as you well know, Rh antibodies bind fairly well to Rh antigens. However, if you do the same thing and you throw in a proteolytic enzyme, and that proteolytic enzyme goes and cleaves some of those Glycoforeign A molecules, well, guess what happens? We've cleared the forest a little bit, and that antibody has more access to the surface of the Rh antigens that are closer to the surface of the red cells, and that can lead to, and in fact does with Rh, lead to stronger binding of the Rh antigens, Rh antibodies, I should say. So that leads me to the enzyme classification, and this is what we're going to use in just a minute to go through the different blood groups. Basically, you throw in proteolytic enzymes with antigens and antibodies, red cell antigens and antibodies, and you can either enhance their effect, decrease their effect, or basically leave them unaffected. And these are the main groups that we're going to talk about in just a few minutes. But before we get to that, let's talk about a couple of other things. Neutralizing substances, which inhibit antibody activity against red cells. I can explain this by showing it to you easier. Imagine that you have anti-A, you put it in a test tube with group A RBCs. Well, you know what you're going to get. You're going to get agglutination. Group A antibodies bind to group A red cells fairly nicely. Okay, but what would happen if before you did that, you threw in soluble group A, or group A antigen? In other words, it's just floating free. You mix that with your anti-A, and then add that to the mixture that contains group A RBCs. You actually get neutralization. You get all the binding sites of that anti-A being taken up, so that in the end you end up with unagglutinated red cells. So that's neutralization, and there's a lot of weird neutralizing substances. You see them here on the slide. My favorites for the P blood group, the hydatid cyst fluid and pigeon egg white stuff, which is just craziness. But again, that's not something we're going to take a lot of time to talk about today. We'll talk about some of these as we go through the different blood groups. You should also know about lectins. Lectins are basically plant-derived or seed-derived substances which act like antibodies, basically. You throw in dolichos bifluorous lectin, for example, and at the concentrations that we use in blood banking, it will agglutinate cells that are blood group A1, but not cells that are blood group A2. And you see further examples here on this slide. Lectins are especially useful when you're working up polyagglutination, and you see a couple of those that are used towards the bottom for T and TN type red cells, and again, that's deeper than we intend to go in this lecture. General characteristics of antigens and antibodies. Well, blood group antigens are present on red cells, but not necessarily exclusively, and they are targeted by an allo antibody. In other words, an antibody against someone else's red cell antigens. That's the definition of a blood group antigen. There's over 325 of these suckers out there, and many of them are gathered into blood group systems that we'll talk about today, which are genetically linked blood group antigens. There are 30 according to the International Society for Blood Transfusion, or the ISBT, and we'll show those 30 on these two slides. We're not going to talk about all of them, but we're going to talk about a lot of them, most of them on this first slide, and some of them on this second slide. This is just to give you an idea of how many are out there. Further, the general characteristics of blood group antibodies include categorization as clinically significant and insignificant. Significance means that they cause hemolytic transfusion reactions or hemolytic disease of the fetus and newborn. Warm reactive, as I said before, those that react best at IAT. Cold reactive are those that react best at room temperature or below 37 degrees. And there are some characteristics that are classic for warm reactive and cold reactive antibodies. In general, warm reactive antibodies are primarily IgM. Warms are IgG, colds are usually IgM. Warms usually require exposure through pregnancy or transfusion, whereas colds are generally naturally occurring, meaning pregnancy or transfusion doesn't have to happen. Warms usually do cause hemolytic disease of the fetus and newborn, or have that potential, whereas colds usually don't. Same thing with hemolytic transfusion reactions, and the same thing with clinical significance or insignificance. Now you notice there's an asterisk by the bottom three entries on the right under the cold antibodies, and that's because some of these antibodies are exceptions to the rule. In particular, the ABO antibodies are the big exception to the rule. ABO antibodies are primarily, as we'll talk about, they have a large quantity of IgM. They're primarily cold reactive. They react best at colder temperatures, but they obviously are very significant because they react very well at warm temperatures. All right, so now that we've done that, let's hit the specific blood group systems. We're going to talk first about the ABO-related systems under the enzyme-enhanced blood groups, meaning you use proteolytic enzymes, antibody and antigen interactions get stronger with these blood group systems. And so the ABO-related groups are ABO, Lewis, Big I, and P, and we'll hit those one by one, and then we'll hit RH and KID. All right, so ABO. In order to understand ABO, you have to understand a little bit of biochemistry. There's two basic types of chains on which ABO antigens are built, and those are called creatively the type 1 and the type 2 chains. The type 1 and type 2 chains really differ in a couple things. First, they differ in how the terminal galactose is bound to the subterminal N-acetylgalactosamine. Not super important for you to remember that specific detail, whether it's galactose, N-acetylgalactosamine, but remember that last residue is important in terms of how it binds. And then the quote-unquote R group. In other words, what's going on with the rest of the chain? Well, let's talk first about the type 1 chain. In the type 1 chain, you have a couple of things going on. First, that last residue is bound to the subterminal N-acetylgalactosamine with a beta-1,3 linkage. Okay, great. But more importantly, from our perspective, is that the R group, in other words, the majority of the chain, is primarily glycoprotein, and those chains are primarily found in secretions. Now, they're also present on the surface of red cells to an extent, but here's how I want you to think of it. I want you to think of it as primarily glycoproteins, some glycolipids, but primarily glycoproteins in secretions as being type 1 chains. Type 2 chains, on the other hand, have a different linkage. They have a beta-1,4 linkage there, and they are primarily found on red cell membranes, so they're primarily glycolipid. Okay, so type 1 chains, glycoproteins in secretions, also somewhat in plasma, but glycoproteins in secretions primarily. Type 2 chains on red cell membranes and primarily glycolipid. That distinction will become important in just a second. When we're talking about type 1 chains, in order for a type 1 chain to do anything in the ABO blood group system, the first thing that has to happen is you have to have the action of a particular gene product. That gene is called the secretor gene, or the SE gene, also known as FUT2, F-U-T-2. FUT stands for fucosyl transferase. So that gene makes an enzyme that adds fucose to type 1 chains right there at the terminal galactose. 80% of us are capable of doing this. That means that 80% of us are so-called secretors. When that happens, you have just made an antigen which is known as H antigen. Very important to understand H. This is what we call a type 1H, meaning it's occurring on a type 1 chain. On the other hand, on a type 2 chain, an enzyme which is made by the H gene does exactly the same thing. So that enzyme causes the addition of a fucose onto that terminal galactose. Just about everybody can do that, and what we've made when we do that is type 2H. You have to have H. H is required for A or B antigen formation, and from the point of either a type 1 H chain on the left or a type 2 H chain on the right, from there you can go on and add one additional sugar to that terminal galactose and end up with either A or B antigen. So again, let me show you how this works. For the blood group A, those individuals have a gene which is the A gene, and that A gene makes a N-acetylgalactosamine transferase. As a result, an N-acetylgalactosamine gets added onto that terminal galactose, and you have blood group A. On the other hand, for blood group B, the B gene product is a galactosyl transferase. So a galactose gets added on to the other galactose, and you have blood group B. That's all the difference between blood group A and blood group B. Now, I'm showing this on a type 2 chain, but the truth is it happens the same way for a type 1 chain or a type 2 chain. So you can make group A or B antigens in secretions with type 1 chains or on the surface of red cells with type 2 chains. ABO antigens have a very specific characteristic in that when we do what I just showed you on the last slide, when we make either A or B antigen, that chain no longer carries H antigen specificity. In other words, the more A or B you make, the less H you have remaining. That leaves you with the relative amount of H antigen that'll make more sense in just a minute, where blood group O has the most H and blood group A1B has the least H. ABO antigens are coded for by 3 different genes on chromosome 9, the A, the B, and the O gene. The O gene doesn't actually do anything. A and B do what I've already showed you. And note that the genes don't code for the antigens themselves, they code for an enzyme, which makes the antigen. The antigens are there fairly early, about 6 weeks estimated gestational age, and they come to adult levels by age 4, and they're also found on a multitude of other areas of other places aside from just on the red cells, including platelets and endothelial cells, etc. Antibodies appear only after 4 months after the baby's born, and they don't get to adult levels until about age 10, and over the course of time, in the very elderly, those antibodies can fade. Probably not as much as we used to think, but they can fade over time. The antibodies do differ by blood group, and this is so big, important for you to recognize this. Everyone agrees that blood group A and B carry IgM antibodies. In other words, the anti-B that a group A person has and the anti-A that a group B person has will be IgM. They are naturally occurring. They don't cross the placenta. They're classic IgM antibodies. On the other hand, there's some disagreement with blood group O, but the current version of the technical manual describes it this way. Basically, they say that anti-A and anti-B in a blood group O person is primarily IgG rather than IgM. And in addition, people that are blood group O have an additional antibody called anti-A comma B. Now, anti-A comma B is clearly IgG. I don't think anyone disagrees with that. And it can't be separated into the individual parts. And that leads to a scenario where people that are blood group O, moms in particular that are blood group O, have ABO antibodies that can cross the placenta and cause some damage to the baby. And we'll talk about that in just a moment. ABO types by race, we're not going to spend any time on this other than just make sure that you recognize that this order that I show you here on the left, O, A, B, AB, that's pretty much true across most racial boundaries. You see 4 racial boundaries listed here, and that order stands in place for all of them. There are differences in relative percentages, obviously, but just remember it that way and you'll be in good shape. The genotypes we've already talked about. Individuals who get 2 O genes will be blood group O, and individuals who get 2 A genes as well as an A and an O gene are group A. Same thing with B, and if you get an A and a B gene, you are group AB. All right, let's talk a little bit about the specific blood groups in the ABO blood group system. Blood group O, first, is the most common blood group across all racial lines. We've already mentioned that. The antigen on its surface is only the H antigen. Remember, if you don't make A or B, you're left with H. You can tell a blood group O by using Eulex europaeus lectin. Eulex reacts against cells that have a lot of H, so not just blood group O, but obviously it would react against blood group O. And we've already talked about the antibodies, and as a result of the IgG component of those antibodies, the blood group O gives you the most common, but usually fairly mild form of hemolytic disease of the newborn. You may wonder what that little icon is there after HDFN. That's a little flashlight, and that's because I call this fact a flashlight in the eyes. It's so important that it should be reflex to you. I should be able to shine a flashlight in your eyes and say, what's the most common form of HDFN? And you'd spit out immediately, group O mom, group A or B baby. So that's you'll see this kind of scattered throughout this lecture, but that's what I'm going for with that. Group A is the second most common. You see the percentages there. They have A antigen and H antigen in some proportion, more on that in a second, and they have a naturally occurring IgM anti-B that reacts against, obviously, group B cells. Now, there are 2 subgroups of A that you need to be aware of. They are group A1 and group A2. And you can basically divide everyone who's blood group A into A1 and A2. It's not completely true. There are some much less common, less than 1%, additional subgroups, but roughly 80% are A1 and roughly 20% are A2. Now, in terms of excuse me, in terms of how these blood groups differ, well, basically the big difference is that blood group A1 has 5 times more A antigen on its surface than blood group A2 does. So if you look at the bottom of the slide here, I put together a fabulous fabulous animation just so that you can see what I mean by that. Isn't that good? Yeah, lots more A on a group A1 than on a group A2. So think about that for a second, though. What does that mean in terms of relative amounts of H? And if you think back for a second, you remember the more A you make, the less H you have. So an A1 red cell will have less H than an A2 red cell. That would seem fairly obvious. Okay, there are also so there's a big quantitative difference, but there are also some qualitative differences as well. There are some differences in the biochemical composition of the A chains on an A2 cell, and of even greater importance, individuals who are blood group A2 can form antibodies against blood group A1, in other words, an anti-A1, and you see the percentages there on the slide. Up to 25% of people who are A2B can form an anti-A1, but fortunately that antibody is usually clinically insignificant unless it reacts all the way up at body temperatures. Blood group B, on the other hand, is not all that exciting. I'm sorry for those of you that are blood group B. You have a kind of a boring blood group. It has B or H and B and H antigens. It has an IgM anti-A, and there are some subgroups there, but they're really not exciting and they're really not common, so we won't talk about them. Blood group AB, on the other hand, is the least frequent of all blood groups across all racial lines, roughly 4% in Caucasians and African Americans. They have the A and the B antigens and hardly any H at all. And remember, we talked about that relative proportion. Individuals who are group AB can actually be further classified into subgroup A1B or A2B, depending on what their A is. And so if an individual is blood group A1B, they would have hardly any H at all. They'd have somewhat more H if they're blood group A2B. People who carry both antigens would not carry either antibody, obviously, so no ABO antibodies. As a result, these folks are designated as the quote-unquote universal recipient. We do ABO testing in the blood bank all the time, and it's important for you to have a good handle on it. Fortunately, this is not difficult to understand. There's several different names that this testing goes by, but on the left side of the table here, the cell testing, also known commonly as serum testing, or I'm sorry, also known commonly as forward grouping. That's what I'm trying to say. So cell grouping or forward grouping basically takes the patient's red cells, or the person you're trying to test, takes their red cells, reacts it with reagent anti-A and reagent anti-B, and that gives you whether or not that tells you whether or not they have with either of those antigens on their surface. For the serum testing, the serum grouping, or the reverse grouping as it's commonly known, or the back typing is another name that blood bankers call it, you take the patient's serum or plasma and react it against reagent red cells, A1 cells and B cells. And so obviously on the top line, if you've got someone who's blood group A, you would expect their cells to react with the reagent anti-A. If they're blood group B, you would expect their anti-B to react against the group B reagent red cells. And you see that's how that works. Notice the fact that for each and every blood group as you go down this table, the reactions are opposite. In other words, the cell grouping or the forward reactions are opposite from the serum reactions. You have positive, negative, negative, positive for blood group A. For blood group B, you have negative, positive, positive, negative. If you don't have that inverse relationship, or that opposite relationship for every test that you're doing, then by definition you have what's called an ABO discrepancy. ABO discrepancies are a lecture in and of themselves, and we clearly don't have time to go through that, but just recognize that you can have issues either with the antigens or with the antibodies. You can have missing antigens in subgroups or transfusion or transplant, for example. You can have antigens that are there that shouldn't be, and there's a wide variety of reasons for that as well. You can also have antibody problems where you don't have antibodies that you should have, immunodeficient patients, for example, or in different subgroups or in transfusion, or you can have unexpected antibodies that shouldn't be there that are, and a lot of reasons for that as well. Overriding all of that is technical problems. Obviously, if you do the testing wrong, you can completely screw up everything. For most of these blood groups, I'll talk about just a couple of things that are kind of odd and strange, just so you'll have an idea of some of the things that are important to know, just not only for trivial purposes, but if you're going to take an exam, these things tend to get focused on. For one of the ABO discrepancies that doesn't happen all that often, but is fairly famous on examinations, is the acquired B phenotype. That's a scenario where blood group A1 red cells come into contact with enteric gram-negative organisms. In other words, bacteria from the gastrointestinal tract. That happens with colon cancer, gastrointestinal obstruction, or sepsis, and they present with an ABO discrepancy that looks kind of like this, where you have a strong reaction with anti-A on the forward grouping, a weaker reaction with anti-B, but you would interpret that forward grouping as AB, and just a straightforward group A interpretation on the reverse grouping. Well, that's a fairly classic appearance for acquired B, and again, ABO discrepancies are a lot. They're a big topic in and of themselves, but when you see something like this, the one reaction that's out of place is that weak 1 to 2 plus reaction with anti-B. So that's where you would focus your energy. Knowing the clinical history, you would go fairly quickly to acquired B. This is not the only thing it can be, obviously, but here's how acquired B works. That terminal N-acetylgalactosamine for blood group A gets damaged by gets damaged by those enteric gram-negative bacteria, and you end up with a free-floating acetyl group, or the acetyl group comes off, and you're left with not quite galactose, but something that looks kind of like galactose, and close enough that our reagent antibodies will react, but it's not really a blood group B. That's why it's called an acquired B. There's a lot of ways to resolve it, including acidifying the serum, auto-incubating. In other words, if you mix this person's own anti-B with this reagent, with this acquired B, you're not going to get any reaction because it isn't really a true group B. You can also use a different form of monoclonal anti-B in your typing that doesn't recognize acquired B and go from there. There's also the Bombay phenotype in the ABO blood group system as one of the weirdos. The Bombay phenotype is the OH phenotype. Basically, these individuals have no H antigen, no A antigen, and no B antigen because they have neither the H gene or the SE gene, the two genes that I talked about at the beginning that make H antigen. So that's their genotype you see on the second line there. Sorry, the third line down, little h, and little se. They have a strong anti-A. Remember, anti-A occurs when you get it when you don't have A antigen. Same thing with anti-B, but in addition, their big problem is that they get anti-H. Basically, that means that while they look like blood group O on your basic testing, they have an antibody that will react against basically every other red cell that carries any H at all. So the only way you can transfuse them appropriately is to use blood from another Bombay donor, another H negative donor. Para-Bombay is similar, it's just that those folks are secretors, so they have a smaller amount of H antigen present and in their secretions and to some extent in their plasma. Less of an issue, but they still need H negative blood. Okay, so let's move on to the Lewis system. And remember, Lewis is part of the ABO family. It's related to ABO. The Lewis gene, or the LE gene, is called also known as FUT3, and as a result of that, you should know kind of what it does. It's a fucosyl transferase. The distinction is the Lewis gene product only acts on type 1 chains, and it adds the fucose not to that terminal galactose, but to the subterminal N-acetylgalactosamine. When you do that, you've just made an antigen which is known as Lewis A. Now, don't get confused. There's no such thing as a Lewis A gene and a Lewis B gene. There's just one gene. It's the Lewis gene, and it does this. It makes Lewis A. In order to make different Lewis antigens, you have to have the action of some other genes. Well, we already know about something else that acts on type 1 chains, and that's the SE gene, or the secretor gene. The secretor gene, as we know, throws a fucose onto the terminal galactose on a type 1 chain to make type 1H, as we've already talked about. So if that happens, in addition to the Lewis gene doing its duty and putting on a fucose on the subterminal galactose, then that combination, the presence of both of those fucoses, gives you not only H antigen activity, but also Lewis B activity. Okay, so remember, Lewis B is formed through the interaction of both the SE gene product and the Lewis gene product. So both occur. Again, don't get confused. You can have H activity and Lewis activity at the same time. You can't do that with blood group A or B, but you can do it with Lewis. Okay, so let me show you kind of graphically how this goes. Let's imagine the life of a type 1 chain that's sitting there with nothing being done to it. You've seen this up close before. So imagine this type 1 chain, and it has a couple of things that can happen. First, either the Lewis gene product can act on it first, or the SE gene, the secretor gene product, can act on it first. Let's just imagine that the Lewis gene product acts on it first. Okay, if that happens, then we make Lewis A, and you know what, you've seen that before. The fucose gets added to the subterminal in acetylgalactosamine. What actually happens in real life is that things stop right there. That particular chain is not going to go on and have the SE gene product act on it. It's just as a result of steric interactions, and it's, again, more complicated than what I'm telling you. But if the chain goes down that pathway, it doesn't do anything other than Lewis A. Fortunately, the SE, or the secretor gene product, is better than the Lewis gene product and faster, so most of these type 1 chains are going to go down the pathway on the right, which is the SE gene pathway, the secretor gene pathway, and be changed into type 1H. After that happens, if a person, for example, is blood group A, then that particular chain can have the A gene product act on it or the Lewis gene product act on it. If the A gene acts on it, then it goes from type 1H into A. If the Lewis gene product acts on it, then it still retains its H activity, but it's also Lewis B, as we've talked about before. And that's the pathway that most of these type 1 chains go down. Now, in addition, that gene product, or sorry, that chain can also undergo Lewis activity. So it's absolutely possible to get a chain with both Lewis B activity and blood group A or blood group B activity, depending on what the individual is genetically. Okay, so why are we even talking about this as a blood group or as a system? Because as you know, we've already described type 1 chains as occurring in secretions and not on red cells, and that's absolutely true. But I also mentioned that type 1 chains do float free in plasma, and as a result, these antigens can kind of stick onto the red cells or adsorb onto the red cells. Lewis B is much better at doing this than Lewis A. So as a result, if you look at the bottom of the slide on the left, you'll see that floating around in secretions, in the plasma, you can have a lot of Lewis B, usually not much Lewis A. Remember, the secretor gene product usually acts on type 1 chains first, so you usually will get Lewis B rather than just Lewis A. Then Lewis B is better than Lewis A at adsorbing onto the surface of the red cells, so this is kind of how it looks. With the image on the right, you have red cells that look like they're Lewis A negative, B positive, but the reality is that there is Lewis A around. In other words, if you think about it, it's not possible to make Lewis B without having the ability to make Lewis A, right? You can't do Lewis B without having some Lewis A around. That's important, and we'll describe that in just a second. So when it comes to antigens and antibodies, there are 3 different possibilities that you see there for Lewis phenotype. The most common one by far is Lewis A negative, B positive. 22% of African Americans are Lewis A negative, B negative, though, versus only 6% of whites. And the antibodies to Lewis against Lewis antigens they're cold reactive, and as opposed to ABO antibodies that are IgM and cold reactive, these are not significant. They are IgM, generally insignificant. They're only seen for the most part in people who are Lewis A negative, B negative, for reasons that we've already talked about. Remember, if you look like you're Lewis A negative, B positive on your red cells, you still have Lewis A around, so you're not going to make an anti-Lewis A. The antibodies themselves are insignificant, as I said. Hemolytic transfusion reactions are rare, and hemolytic disease of the newborn is not seen because these antibodies are IgM and can't cross the placenta, and those conversions of type 1 chains that I mentioned to you before only happen after the time of birth. A couple weird things about Lewis is that antigens do decrease during pregnancy, and these patients can go from Lewis A negative, B positive to all of a sudden being Lewis A negative, B negative, and in fact can make antibodies in those scenarios. Fortunately, that's usually not a big deal. Children can have variable Lewis types, I should say, as their chains are converting, and there's a couple of facts down at the bottom about attachment of different infectious organisms through the Lewis B chain. All right, a couple things on the I system. Remember, this is also part of the ABO family. We have we've talked about ABO and H. We've talked about Lewis, and now we're talking about big I. These are related to the ABO blood group system. They are, in fact, type 2 chains. There are two antigens in the I system, big I and little I. Big I tends to occur in adults, and while little I predominates in children. And basically the difference between big I and little I is not so much related to a specific sequence of residues on a chain, but it's more the three-dimensional structure of the chain. Older people have greater branching of their chains. And let me just show you that. So you have a type 2 chains that's kind of sitting there doing nothing. But and that's how babies' type 2 chains are. But as you get older, those chains get more complex and you start branching. And the more those chains branch, the more you get complexity to the chain. And the more complexity you get, the more the antigen present is big I rather than little I. And that brings me to one of my favorite illustrations about the I blood group system. And that's that big I tends to occur in big people, while little I occurs in little people. Shouldn't be too terribly hard for you to remember, I hope. Here's a couple of other things, a couple of flashlights in the eyes when it comes to this system. The first is that auto-anti-big I is classically associated with mycoplasma pneumonia, in older patients especially. It's also the antibody that's usually the target in cold agglutinin disease or cold reactive autoimmune hemolytic anemias. Auto-anti-little I, on the other hand, is classically associated with infectious mononucleosis, especially in younger children. And that would certainly make sense based on what we know. The P blood group system, or the P system, is absolutely my favorite system, not because I have a special attachment to it, not because I've seen antibodies more than any others. I just think there's so much weirdness in this system, it makes me laugh. The P system is based on ABO-related chains. There's only one antigen in the P system, and it's not the P antigen. That really hardly makes any sense at all. It's actually P1. There are a couple of other related antigens, the P and the PK antigens, that help define the overall P system type. And you see that on the fourth row down. Most people are phenotype P sub 1, meaning they carry the P antigen, the P1 antigen, but lack the PK antigen. Rarely, some people can lack all three of those antigens and have acute hemolytic transfusion reactions and spontaneous abortions as a result when that antibody occurs. The P antigen is the receptor for parvovirus B19, easy to remember. The antibodies against the P1 antigens are cold, insignificant IgMs, no big deal. They are seen in greater frequency in people who are associated with bird handlers, and especially in those with hydatid cyst disease. And that should help you remember what we talked about before, is that some of these antibodies can be neutralized with the use of pigeon egg fluid from pigeon eggs, I can't talk, and as well as from hydatid cyst fluid. There is another association with the P blood group system that you should know about, and that's the association with paroxysmal cold hemoglobinuria, or PCH. PCH is a biphasic IgG that reacts against P antigens, and that biphasic IgG is known as the Donath-Landsteiner biphasic hemolysin. Basically what happens is that IgG binds to red cells at cold temperatures, and when the red cells are warmed, then the red cells are hemolyzed, and obviously the antibody dissociates. That's why it's biphasic. It used to be seen in association with syphilis, and now it's seen commonly in association with viral infections in children. All right, so that's everything from the ABO family. Let's move on and talk about the RH system. I promise things will go faster from here on out. The RH system was defined in terms of the terminology by Drs. Fisher and Race in England. Basically, they defined five different antigens, the big D, and then two pairs of other antigens, big C and little c, big E and little e. In the Fisher-Race terminology, Rh positive simply means D positive, and Rh negative is described as having a little d, but there really is no such thing as a little d antigen. More on that in a minute. Dr. Wiener, on the other hand, described what's known as the Rh-HR terminology, and he gave different names for those five main antigens, but really those are not important for us in blood banking now. Hardly anybody even remembers them, and very few people use them. Some do, but very few. But his main contribution was that he believed that the Rh genes were inherited as a group, one haplotype from each parent. And let me show you how he described this. His terminology is still used, though his understanding of the actual genetics was not quite correct. He believed that basically there were these three genes, or these three alleles that you got as a group from each parent, or a so-called haplotype, that you either got a big D or a little d, a big C or a little c, and a big E or a little e from each parent. That haplotype came and in concert with the other parent's haplotype would give you your overall Rh genotype. Now, what I would like you to do when you look at this and you see this terminology DCE, I would like for you to think of the C position as position 1 and the E position as position 2. That'll become clearer exactly why I want you to think of that in just a minute, but for now, just fix that in your brain. The C is 1, the E is 2, and that's alphabetical, so you can remember that. Okay, so anyway, so you got one haplotype from one parent, one haplotype from the other parent, and your overall Rh genotype and resulting Rh phenotype was based on this combination. Now, we know now that Dr. Wiener wasn't quite right. There are actually two genes that give you your Rh genotype, and that's the RhD gene and the RhCE gene. With the RhD gene, again, you get a big D or the lack of big D, whether that's a mutation or whatever. And then for the RhCE gene, you have the possibility of 4 different alleles. And those alleles include big C, little c, big E, little c, little e, and big C, big E. You can see those on the right side of the slide there. So the genetic wheel spins, and in position 1 you get either a big C or a little c. In position 2 you get a little big E or a little e. Again, keep that in mind. More on that in just a second. Again, the haplotype theory is certainly true. You get one of those from one parent, one of those from the other parent. In the end, that determines what your Rh genotype is. Okay, so now we have to do something that's not necessarily fun, but you gotta, Dr. Wiener put specific abbreviations to these haplotypes, and you gotta know them. It's just all there is to it. Whether you're working in a blood bank or whether you're taking an exam about blood banking, you gotta know what these abbreviations stand for. And fortunately, they're pretty easy, and let me show you how to do this. Okay, there are 8 different abbreviations. You see them listed here on the slide in the big box in the middle. Big R1, big R2, big R0, big RZ, and then little r prime, little r double prime, little r, and little ry. Okay, the great news is that the first thing that you have to remember, which is whether or not these have a big D or a little d, is simple, because if it's a big R, it's a big D. If it's a little r, it's a little d. No problem. So it's really easy to generate that first memory slot, which is whether it's a big D or a little d. Okay, no sweat, right? Well, so now we have to figure out what goes in the next spot, and that's in those spots you're going to have, and you see these 4 listed on the bottom of the slide, either the allele with a big C and little e, the one with a little c, big E, etc. So how do you determine that? Well, the easiest way to determine that is to take a look at each of these rows, and I've written these in these rows for specific reasons. Big R1 and little r prime, or 1 prime, carry the same RhCE allele. In other words, in position 1 you have a capital letter. Position 1, as you recall from before, is the C position. So as a result, if you have big R1 or little r1 prime or little r prime, then the big C, little e goes there, right? That's not too terribly hard. Let's move down to the next one. Big R2 or little r double prime. Well, take a guess. Position 2 is the one that's capitalized, and you can see that the next one on the list, the one where where E is capitalized and C is not, is the little c, big E. And you can kind of see where we're going with this. R0, or just plain little r with nothing, means that neither one is capitalized, so you get the little c, little e. And then finally RZ, or any letter, RZ or little ry, will give you both being capitalized, or big C, big E. Okay, so that's what we're left with, and this is absolutely a flashlight in the eyes. You gotta know this terminology. You gotta know how these abbreviations work. Fortunately, there are only 4 of these that actually occur with any great degree of frequency in our population, and those 4 are big R1, big R2, big R0, and little r. Those make up over 97% of people that you'll see It's important for reasons of test taking primarily, but also somewhat in real life, to have an idea of the relative frequencies of those four in both African Americans and Caucasians. And there's a couple of rules. Your handout talks about this as in terms of how to do this. It's pretty simple. Take a few minutes to do this after I do it, and you'll see it's not a big deal. So big R0 is always the most frequent in African Americans and the least frequent of those four in Caucasians. Little r always comes second. And now you have two slots to fill for both, and big R1 always comes before big R2. With that, you're left with this relative order of frequency of the main four, or the big four, RH haplotypes. Again, as we go through, you'll see some questions on the Blood Bank Guy website that talk about how this is utilized. We don't have a lot of time to go over that today, so we're just going to continue on. Okay, the Rh antibodies, I should say, that they are exposure-requiring warm-reacting IgGs, exactly the opposite of ABO antibodies, and they are certainly, the D antigen in particular is the most immunogenic non-ABO antigen that we have out there. We used to believe that as many as 85% of Rh negative people or D negative people would make an anti-D when they were exposed to a single unit of D positive RBCs. Recently, though, that number has dropped pretty substantially, and hospitalized patients that are in that situation, are primarily patients that are losing a lot of blood, that have a lot going on, and they are much less likely than what we thought before. Roughly 20 to 30% of them will make an anti-D, which is still pretty substantial. These antibodies are significant. They cause hemolytic transfusion reactions, usually extravascular ones, and they cause the classic prototypical hemolytic disease of the fetus and newborn. You can also get hemolytic disease with anti-little c, but the other Rh antibodies are fairly, hemolytic disease is fairly mild. Now, please note that I've only talked about, in the Rh system, I've only talked about the 5 main antigens and antibodies against those 5 main antigens. There are 50 Rh antigens out there, and I haven't talked about a lot of the any of the other ones at this point. Again, not enough time to do that. That'll be a separate lecture. Weird stuff in the Rh system include the fact that D negative is not just you don't have a D. There's a lot of weird stuff that goes on, and depending on your race, you can be D negative for a variety of reasons. Caucasians usually are D negative because they've deleted the gene entirely. African Americans, on the other hand, have a pseudogene, a gene that just doesn't do anything. And Asians, on the other hand, have RHD there, but it's just inactivated. So again, lots of different reasons to be D negative, and we describe it as little d, but there's, as I said before, there's no such thing as little d, and there's a lot more to it than that. There are several variants of D that you should be aware of. I mentioned weak D and partial D here. I'm not going to talk about del or D elution. That's, again, a topic for another day, but let's talk about weak D and partial D because people confuse this a lot. With weak D, that's a scenario where an individual really is D positive. However, they have a normal D, an externally fairly normal D antigen. However, they're quantitatively less. Their reactions are less strong, with anti-D. So those individuals, as you see on the bottom of the screen here, they can have a situation where when you test their red cells for the presence or absence of D, you throw in anti-D, and in most situations now, people who are really D positive, that's just going to give you a direct agglutination. You're going to get a positive reaction. However, people who are weak D, by definition, get coating of their red cells, but not agglutination. And in order to see that agglutination, you have to do what's called the weak D test, which is basically just an indirect antiglobulin test. You see it at the bottom of the screen. You have coated, D positive coated red cells. You add anti-human globulin, you get visible agglutination. Does not happen very often at all, and there's a wide variety of reasons that it can occur, including mutations, including the so-called C in trans, where you have a big C little e allele opposite the RHD allele. Functionally, though, what this comes down to is that the only people who really need that weak D test, or the IAT, for someone who appears to be D negative are blood donors. If you're a blood donor and you test as D negative, we are required to do a weak D test on you to make sure you're not really D positive for that, because it has the potential, if your blood went to someone else, of immunizing them. It's done very uncommonly for D negative recipients, on the other hand, primarily because it just it's very uncommon nowadays because of the strength of our antibodies that we have. In addition, if you do the weak D test on someone who appears D negative, you may actually inadvertently harm a recipient, because you might pick up a partial D. In other words, someone who's partial D, who shouldn't be called D positive as a recipient, more on that in a second, may be called D positive. Finally, the only people who really do need weak D testing in a hospital transfusion service are D negative babies with D negative moms. Basically, that's going to give you an idea whether or not you need to give that mom RHIG, whether the baby really is D positive. But otherwise, the testing is good enough that you really don't need to do the weak D testing. For partial D, on the other hand, partial D is confusing to people. Basically, with partial D, you're lacking certain portions of the D antigen, or certain epitopes, antibody binding sites, on the exterior part of the red cell. Weak D does tend to have some deletions and lacking certain epitopes, but it's usually on the interior part of the red cell, so it's less of an issue externally. So if you lack those epitopes and you're exposed to excuse me, D positive red cells, then you can develop antibodies against the part of the D antigen that you lack if you have partial D. So when these individuals are recipients, it really actually is important for them to get D negative blood. And the current forms of anti-D, the most common ones that are used, actually will call the most common forms of partial D recipients D negative, and that's exactly what you want. That's the reason that doing weak D testing can actually harm you in those situations. D negative moms who have partial D actually need RHIG prophylaxis, because if you're partial D, if you're partial D and you're a mom and you're exposed to babies' D positive red cells, you can form, as I said, antibodies against the portions that you lack. Differentiating weak D from partial D can be really, really hard, to be honest. It can require, absolutely can require genetic testing, and in fact usually does, to be completely sure. So if you're not sure, be as conservative as you can. If someone might be partial D, treat them that way and avoid exposing them unnecessarily. Okay, so a lot on ABO family and RH, but we're going to move fairly quickly through the rest. The KID system is the last of the enzyme enhanced blood groups. There are two main antigens in the KID system, JKA and JKB. A is somewhat more common than B, and that's unusual. In most blood group systems, the B is more common than the A, but that's neither here nor there. The KID system is famous for having antibodies that require exposure. They're warm reacting. They're usually IgG, but they may have an IgM component. In fact, 50% of KID antibodies will fix complement. That shows you that that's probably the proportion that has an IgM component, because IgG doesn't usually fix complement. They have marked dosage. The two big famous things about KID antibodies are that they have marked dosage. In other words, that they can easily react completely negative against a heterozygously expressed KID antigen and react very strongly with a homozygous KID antigen. And they have variable expression over time. In other words, the antibody can form, it can be obvious, and then as time goes by, it can completely disappear. And that's why KID antibodies are famous for causing delayed hemolytic transfusion reactions as well. A lot of famous stuff for KID, right? Anyway, these reactions are usually anamnestic. In other words, they have an antibody, it goes away as far as we can tell. Usually happens when someone is transfused at a different facility, or if they were never tested after they developed the KID antibody. We don't know that they have that antibody. They're re-exposed. Coincidentally, the antibody comes back and it causes a severe intravascular form of hemolytic transfusion reaction. As far as hemolytic disease of the newborn, that's usually not an issue, primarily because it's difficult for KID antibodies to react against heterozygous expressions, which, when you think about it, that's what it would have to be. All right, so we've done the enzyme enhanced systems. Let's do the enzyme decreased systems, and finally we'll finish up with the unaffected ones. In the decreased systems, you have the MNS, the Duffy, and the Lutheran systems, and we'll start with MNS. MNS, we talked about this a little bit before when we were talking about enzymes. MNS antigens are carried on glycoproteins, which are known as glycoforeign. There are two of them, the glycoforeign A and the glycoforeign B chains, and glycoforeign A carries M and N, whereas glycoforeign B carries big S, little s, and a very important antigen known as U. More on that in a second. So here's just a quick schematic of a red cell membrane. You've got a glycoforeign A here that we're showing, which is a transmembrane glycoprotein. The last 5 amino acids on a glycoforeign A chain are what distinguishes a glycoforeign A that has M activity from a glycoforeign A that has N activity. And you see those here. The exact order is not really important for you to memorize, but you see position 1 and position 5 are the only differences. Okay. On the other hand, glycoforeign B, excuse me, glycoforeign B is also transmembrane. It's a little shorter. There's only one amino acid difference between glycoforein B that has S activity, big S, from glycoforein B that has little s activity. Either form of glycoforein B also carries down near the surface activity for the U antigen. U pretty much stands for universal, so you can imagine that it's very, very high frequency. In the MNS system, the amount of M antigen roughly is equivalent to the amount of N antigen, or the number of people that are M positive is equivalent to those that are N positive, I should say. Little s is more frequent than big S, and very important that only about 2% of African Americans completely lack big S, little s, and U. That's never seen in Caucasians. Why is that a big deal? Well, it's primarily a big deal because of the fact pardon me, that those individuals tend to be the ones that completely lack glycoforein B. The big S, little s thing is not that big a deal, but if you make an antibody against something that stands for U, universal, you're going to have a potential problem. Okay, so there's also a lectin, Vicia graminea, that acts on group N positive red cells. The antibodies from these two different groups are actually somewhat different. In other words, when you think about the MNS system, you can kind of divide that down the middle. In other words, you have the M and N antibodies, and then you have the big S and little s antibodies, and they're almost completely different. Anti-M and anti-N tend to be naturally occurring, whereas big S, little s, and U antibodies require exposure. Anti-Ms are IgM and anti-Ns, but that's easy to remember, right? Anti-M is IgM, whereas anti-big S, little s, and U tend to be IgG. The M and N antibodies are usually insignificant, whereas the big S, little s, and U antibodies are very significant and do cause serious potential problems if they're present. The Duffy system, which is the second of the enzyme decreased blood group systems, have two main antigens, including FYA and FYB, coming from the corresponding genes. The individuals that lack both Duffy A and Duffy B, FYA and FIB, that's seen in 68% of African Americans, very rare in Caucasians, and it's usually due to what's known as the FY-FY genotype. And you notice that doesn't include either the FYA or FYB genes. It's actually a separate gene, and they have no Duffy antigens whatsoever. Again, that gene is seen very rarely in Caucasians, but it's seen in over 2/3 of African Americans. The antibodies, really, when you think of Duffy, with the exception of the enzyme activity, you should think of KID, because those two groups have very, very similar antibodies. They have marked dosage, just like KID. They have variable expression. In other words, they can disappear over time, just like KID, and for that same reason, they can cause delayed hemolytic transfusion reactions, also just like KID, though the severity tends to be somewhat less than with KID, KID antibody-induced delayed HTRs. The weird stuff about the Duffy system includes the malaria resistance thing, and this is so important. Big flashlight in the eyes. People who are Duffy A negative, B negative, FY A negative, B negative, are resistant to both Plasmodium vivax and Plasmodium knowlesi infection, and that's probably because the regular Duffy glycoprotein, which is not seen in people with the FY-FY genotype, is the receptor for those Plasmodium merozoites. So without those, significant resistance to different forms of malaria. All right, the last blood group system within the enzyme decreased groups is Lutheran. I don't have a lot to say about Lutheran. It's not hugely important. The two main antigens, Lutheran A and Lutheran B, LUA and LUB. Lutheran B is the one that's high frequency. Lutheran A is not. The antigens are destroyed by some enzymes, but not all, and they're definitely destroyed by sulfur reagents like DTT dithiothreatol. The antibodies are IgG, except sometimes you can get IgM with anti-Lutheran A. They cause mild hemolytic transfusion reactions at worst and really are not known to cause hemolytic disease of the fetus and newborn. Okay, that's enough for that. Let's move on to the enzyme unaffected systems, and we'll spend most of our time here on Kel, a little bit on Diego and Colton. So you use proteolytic enzymes on these red cells, and it doesn't have any effect. With the Kel system, two main antigens, multiple other antigens, but the two main antigens are big K and little k. Big K is also known as K1. Little k is also known as K2. Just about everybody, when they talk about big K, they'll call it Kel. That's technically not correct, but everybody pretty much knows what you mean. Better to say big K or K1, either way. But the big K antigen is seen in 9% of Caucasians and 2% of African Americans, so it's moderately low frequency. The little k, on the other hand, is seen in just about everyone. And if you look at a couple of the other antigens in the system, the JSB and JSA, KPB and KPA, they are very similar in that the B is high frequency, the A is low frequency, so they kind of correspond. Kx, on the other hand, is an antigen that's closely attached to the Kel antigens on the red cell surface. Even though it has the name Kx, it's not technically part of the Kel system, but it's certainly related, and you'll see in just a second it's important in several significant situations related to the Kel system. Kel antibodies, anti-big K and anti-little k are very, very similar. They just differ in frequency, basically. Big K is a very immunogenic antigen. After D, it's the next most immunogenic ABO antigen, so non-ABO antigens. So people who are big K negative and get exposed to big K are very likely to develop an antibody. That antibody is usually an IgG, which is exposure requiring and warm. Obviously, it can cause severe hemolytic transfusion reactions. It can cause severe hemolytic disease of the fetus and newborn, though it's not really hemolytic. It's a bit of a misnomer. Basically, anti-big K will bind to precursor red cells and suppress them from even forming mature red cells. Okay, so anti-little k does very similar things. It's just very uncommon because just about everybody has little k. A couple of strange things in the Kel system include the Kel null phenotype, or K sub 0. Basically, these people have no Kel antigens at all and have a paradoxical increase in Kx. And not hugely important there, but what is important is that they develop an antibody which is known as anti-Ku, or Kel universal, which reacts against virtually everyone's red cells except other Kel null people. The classic favorite of people who write exam questions is the McLeod syndrome, or the McLeod phenotype. McLeod is defined by the absence of the Kx antigen, so that antigen that sits right next to the Kel structures on the surface of the red cells. That antigen is gone. As a result, you have a decrease in Kel antigens. You have membrane instability, which leads to acanthocytes and acantholytic hemolytic anemia, and the famous association with X-linked chronic granulomatous disease. Now, CGD, important disease that you should be aware of. Basically, it's a lack of NADPH oxidase, and individuals with CGD will develop infections with catalase positive organisms like Staphylococcus, for example. So anyway, that borders on microbiology, and I might get sick if I start talking about micro, so let's move on. That's it for Kel. Let's talk about Diego and Colton for just a second. The Diego system has some antigens that are distinctly different. They live on an anion exchanger protein known as band 3. There's the Diego A, DIA, and DIB pair, which is basically low and high frequency, and the right A and right B, or WRA, WRB pair, which are also the same thing. B is high frequency and the A is low frequency. The antibodies for DIA and DIB are both capable of severe hemolytic disease, but not much in the way of hemolytic transfusion reactions. With WRA and WRB, those antibodies are WRA is usually naturally occurring. It can cause significant disease, but it's not seen all that often. It can cause hemolytic transfusion reactions and hemolytic disease of the newborn. Whereas anti-WRB, because remember, WRB is very high frequency, the antibody is commonly seen as an autoantibody. The Colton system, which is the last in the enzyme unaffected group, actually is a misnomer from the beginning. Colton was actually written on the original test tube as Calton, and someone misread it or someone wrote it badly, and the system has gone by an incorrect name for a lot of years. Doubtful it's going to get changed back. I don't think it will. Anyway, there are two antithetical antigens, the COA and the COB pair. It's unusual in that it's the opposite of what normally happens. COA is extremely high frequency, almost 100%, whereas COB is well, it's not extremely low, but it's lower frequency, about 10%. The antibodies are usually IgM. Both of them can be significant primarily in terms of causing severe hemolytic disease of the newborn, but not all that commonly seen. A couple of different systems that I should mention before we go away include Dombrach, YT, XG, and VEL. VEL is actually not a system, it's an antigen. More on that in a second. Dombrach has a pair, DOA and DOB, as well as 5 additional antigens that are in the Dombrach system, and you see them listed there. Both DOA and DOB are common, and the antibodies, while they can cause acute hemolytic transfusion reactions as well as delayed hemolytic transfusion reactions. So they're significant, but they don't cause hemolytic disease of the fetus and newborn. The YT system used to be called the Cartwright system. These are antigens present on an enzyme known as acetylcholinesterase, which is primarily seen in neural tissue. Why it's on red cells, nobody's really sure. YTA is extremely high frequency. YTB is much lower frequency. The antibody against YTA can cause problems, but the antibody against YTB usually doesn't cause problems. XG is a system that you will see on every single blood or antibody identification panel that you look at. However, the antibodies are usually not an issue at all. It's called XG because the antigen is, excuse me, the gene coding for this antigen is present on the X chromosome. So 89% of females carry the antigen, 2/3 of males carry the antigen as well. And as I said, despite the fact that the antigen is there, it really doesn't cause problems. Let's finish with VEL. VEL is an antigen that does cause substantial issues when it's seen. Fortunately, it's rare. The antibody is rarely seen. I think I said that poorly. It's an antigen that the antibody against it causes substantial problems, but it's rarely seen because the antigen is so high frequency. It's not part of any system. The antibodies, though, they do cause problems because they're an IgG and IgM mix. They can look fairly weak, but despite the fact that they look fairly weak, they can cause very, very serious problems. Severe hemolytic transfusion reactions, severe hemolytic disease of the newborn. They can be autoantibodies, they can be alloantibodies. The alloantibodies are the ones that we usually worry about and deal with most of the time. In addition, because these antibodies have a very broad thermal range, they can react at room temperatures and can cause problems with ABO serum grouping. Anyway, bottom line with VEL is that if someone is VEL negative and has an anti-VEL, they really need VEL negative blood, and that may be an issue sometimes. Most blood centers and certainly rare donor registries have access to substantial numbers at this point of VEL negative blood, so it usually doesn't cause tons of problems once the antibody is finally identified. Okay, well, have I beaten you to death? So to quote Wesley from The Princess Bride, you mean you wish to surrender to me? Very well, I accept. So, thanks so much for hanging around. I know this has been a bit of a long haul. I very much appreciate you taking the time to download this. Please give me feedback both directly and on the website and through iTunes if you're watching this through iTunes. And we'll finish out with a disclaimer, but thank you very much. The pre-transfusion testing and antibody ID podcasts are coming. They may be already there by the time you hear this. Go check them out.